Okay, in this video we're going to look at upper GI pathologies of the mouth and the esophagus. We went in the last video and looked at the assessment and treatment of GI disorders, so make sure you review that if you haven't looked at that already. And then we'll work our way into the stomach in the third video of the series. So what are some common disorders of the mouth? And that's going to include the salivary glands as well. Remember, we have three major salivary glands, the parotid glands, the sublingual glands, and the submaxillary glands. And we have lots of minor salivary glands as well. But mouth disorders will include saliva gland disorders. So mouth ulcers, cold sores, which we usually see on the lips, it can actually happen in the mouth. Oral thrush, which is overgrowth of candida, leukoplakia, gingivitis, and then salivary gland infections, salivary gland tumors, and then salivary gland stones. So we'll look at all of those. There is a medical specialty, so although gastroenterology covers most of the GI tract, there's actually a medical specialty for the mouth, and that is otolaryngology. So otolaryngologists will actually focus on the sinuses, the larynx, that's the voice box, the oral cavity, and the upper throat, the neck and the face. So that is the specialist for the mouth. Now there are some red flags for the mouth. I just list them here. These tables I've adopted from, for full disclosure here, from Claire Stevenson's book, The Acupuncturist's Guide to Conventional Medicine. She has some nice tables. So again, this is a good companion textbook to look along here. But some of the red flags we'd look for would be persistent candidiasis. So this is people where the candida just keeps coming back and back. It's not typical for this to happen. It happens in babies. But this could really indicate things like HIV infection, so a person should be tested, but also diabetes, potential corticosteroid use, and even in some cancers. Leukoplakia, which we'll talk about, these are persistent white plaques on the tongue. These are precancerous, and I'll talk about those here in a minute. Painless enlargement of salivary glands over weeks to months. So that's going to happen maybe temporarily, which is not a problem, but if it's persisting over weeks to months, that could indicate a salivary gland tumor, especially in older patients. And then a painful or painless enlargement of the salivary gland immediately after eating. That's a pretty typical finding of a salivary gland stone. So that would be another red flag there. Tender or inflamed gums would indicate gingivitis, potential abscess, and patients would need better dental care usually for that. And then any mouth ulcerations that are persistent over a week or that prevent proper hydration. And that can be caused by very prolonged herpes infection. Could also suggest inflammatory bowel disease. So we'll look at that one of the manifestations of IBD, inflammatory bowel diseases, and that would be either Crohn's disease or ulcerative colitis, will be in the mouth with lots of canker sores, mouth ulcers, things like that. So these would be some of the things just to keep in mind with the mouth. We usually don't do mouth inspections, but people will come in complaining of a mouth complaint, and so we have to sort of think about what might be going on there. So the first condition, very common, would be aphthous ulcers, or it's called aphthous stomatitis, or canker sores. These are very common, affects up to 20% of the population to some degree. They can be single or they can be multiple ones. They're shallow, they're gray ulcers with what's called a necrotic base, so the skin kind of sloughs off the top, or not the skin, but the mucosa. They can come in crops, and they can come and go over a period of days, and they're often painful. The etiology is unknown, but we think it has to do with an overactive T cell response. So there's an overactive immune response. Again, that's why it's often, these can be associated actually with inflammatory bowel diseases, Crohn's and ulcerative colitis, where the immune system is overactive. Lots of triggers. We know that nutritional deficiencies, different B vitamins, vitamin C, local trauma, burns, chemical burns, thermal burns from hot beverages, stress, hormonal influences like estrogen, allergies, and genetic predisposition are all kind of etiologic factors. They occur periodically. They usually heal completely between attacks. Usually they last about a week. So anything lasting over a week, we're going to get a little bit more concerned that this is not just a simple mouth ulcer. Now sometimes one will heal, another pops up, and that's not atypical. But they should usually take about 7 to 10 days to heal. can be very severe and interfere with eating and drinking. The treatment is really supportive and trying to isolate the underlying etiology and to support that. So these are not precancerous or anything like that, but they can be painful and they can interfere with activities of daily living. Now, we have to differentiate the Apostomatitis from herpetic stomatitis or herpes labialis. Herpes labialis is herpes on the lips, labia. Herpes stomatitis is going to be in the mouth. Usually this is from herpes simplex 1 infection. Genital herpes is usually herpes simplex 2. Now, simplex 2 can infect the mouth, so it's not that one stays in the genitals, one stays in the oral region, but typically most herpes stomatitis is HSV1. The virus actually lies dormant in the ganglia of the trigeminal nerve and goes dormant in the ganglia. That's actually located at the down below the ears, actually, and that's where the ganglion are found. And these can then erupt out and then erupt onto the surface of the skin. So you never really are cured of herpes. It just goes into remission because the virus is always there. It's integrated itself into your neurons, into your nerves. So herpes viruses are very specific. They infect nerves, neurons. Those are nerve cells. They usually form as small vesicles and ulcers, and they form right on the mucosa. Very painful. They have a red base. So unlike the Apostomatitis, notice the base of the aptus is reddish, but it's more kind of flattened and whatnot. Herpes has this very angry looking, and it almost looks like there's fluid-filled blisters, and that's another different feature. So we always want to differentiate these two, aptus from herpetic stomatitis. The treatment here is typically biomedically with antiviral medication. Acyclovir is one example of that. Acyclovir can shorten the duration of the outbreaks. It inhibits the virus replication. We'd also look, of course, at strengthening the immune responses for the body to help with that as well. This is one area where we do look at sexual practices. So oral sex, actually, genital herpes again can infect the mouth. So we often find, for example, with chronic sore throats, that one potential factor there can be chronic herpes infection. So that would be something to look into. Another oral disorder here would be thrush, oral candidiasis, and that's infection with Candida albicans. Forms a very thick white tongue coating, white plaque. You can almost scrape it off. Commonly seen in newborns, and that's because their immune system hasn't really kicked in yet, usually under 6 months. In adults, we find it more associated with immunodeficiency disorders like HIV. Could also happen after taking antibiotics. Happens more commonly in diabetic patients and anybody on immune suppression with cancer treatment. So it'd be common in people with thrush. The treatment is usually topical antifungals biomedically, like nystatin, miconazole, gentian violet, amphotericin B, and then addressing the underlying cause, the immune deficiency. In anyone over 1 year of age, interesting treatment that I've seen work in a few patients is honey, topical honey. You do not want to use that in a neonate or child under 1 because of the potential for botulism. But for older children, adults, that would be something. But again, if this is happening chronically, we have to look at an underlying disorder that might be contributing to that immunodeficiency. Leukoplakia is another oral disorder that's important to keep in mind. And this is a hyperkeratosis. So remember, keratin is that tough protein. It's usually deposited only in squamous epithelium in the skin, not in the oral mucosa. But here we actually get keratin being deposited. There's also hyperplasia of the squamous epithelium. And this is leukoplakia. It's basically usually benign, but it can become malignant. We actually consider it precancerous. Usually associated with heavy smoking, excessive alcohol intake, really poor dental hygiene. In some parts of the world, actually chewing what are called batelquids. That's tobacco made of tobacco dust, the areca nut and lime. It's wrapped in the betel leaf. So all of this, the risks, these are risk factors, and it's going to increase with age. So here, if you look at the lesion, it's again different. It doesn't look like it's rounded and demarcated like the Apostomatitis or the herpetic stomatitis. It's more of a general kind of more nondescript kind of lesion. So if you see that, and again, if it's persisting, that is something that needs a referral or needs a biopsy to really confirm that that's what it is. And it needs to be dealt with. So the treatment's going to depend on the size and the features of the lesion. There is surgical excision that can happen. Usually there's close follow-up then every 3 to 6 months, and then obviously removing any potential risk factors, as well as addressing micronutrient problems. Like we know that zinc is very important for the skin. So is selenium is a trace element, is an antioxidant. So these would be things to, usually through the diet, that we try to increase, maybe working with some herbal therapy as well. So that would be leukoplakia. Now oral cancers, there are really, with the skin, there are 3 different types of cancers. There's squamous cell cancers, and that comes from squamous cells, flat cells. Basal cell carcinomas, and those come from basal cells which in mucosa lie at a deeper level, and then melanomas, which come from melanocytes. So typically, because there are no melanocytes in the mouth, or much less commonly than the skin, we see in the mouth cavity squamous cell carcinomas, but we can get basal cell and melanomas. Usually the oral cancers occur in middle-aged or older adults, so risk increases with age. And again, those same risk factors that we saw with leukoplakia. In fact, leukoplakia can turn into squamous cell carcinoma. Same things lead to oral cancer. So this would be a lip or mouth sore that just doesn't heal. You see white with a red patch on the inside of the mouth. So this is a pretty classic kind of squamous cell. It's raised, looks kind of like a cauliflower. Doesn't have that kind of pale white surface, so just sloughing off mucosa. It's really an overgrowth of the cells here. We might find that there's mouth pain, difficulty in painful swallowing as food kind of brushes back by that. It kind of irritates the surface. So the treatment's going to vary, but depending on the size, it could be surgically resected. For larger tumors, you're going to need to take a big chunk out of the cheek, for example. And then going to have to be concerned about the fact that these cancers do spread to the lymph nodes. So any lymphatic spread that way. So, this is where really timing is important. You catch these in the early stages, they're much more treatable, often 100% curable, versus in later stages, the prognosis diminishes. So we're always on the lookout for oral cancers. If you go to the dentist, sometimes they'll do an exam of your whole mouth and your jaws and your gums, and that's actually one of the things that they are looking for. So jumping into the salivary glands, we of course have the parotid gland, the big one here, front and inferior to the ear. We have the submandibular gland and the sublingual glands, and they're all connected by ducts to the mouth cavity. So we can have several different problems go on here. One is salivary gland infection, C. adenitis, and this most commonly involves the parotid, and then the next most common will be submandibular and then sublingual. It can be acute, and that would be more red, painful swelling that's really tender to the touch. Chronically, there'd be less pain, sort of recurrent swelling over time, usually after meals, less redness. Usually caused by a virus or bacteria. In fact, before the mumps immunization, that was a very common cause. The mumps created these very enlarged lymph nodes, salivary glands, and that's where the name mumps came from. But it can also be caused by autoimmune disease and different cancers. Complications here would be lack of saliva and proper salivary nutrition. So we'd see complications like abscesses, dental decay, facial deformities, and things like that. So the treatment's going to vary depending on the cause. For acute infections, typically antibiotics are given. Augmentin, clindamycin are common agents there. What are called sialogogues are given, and those are kind of sour things like lemon and things like that all stimulate saliva secretion. And then surgery to remove parts of the gland if it's chronically infected and scarred and so forth. So that would be salivary gland infection. Salivary gland stones, sialolithiasis, most commonly affects the submandibular gland. Fairly common, most common in males between 30 and 60. The stones form in a salivary gland when the secretions kind of dry up, and that blocks the flow of saliva. And especially at meal times, what happens is the saliva is blocked from getting out, and it builds up in the gland, causing swelling. This causes pain and swelling in that affected gland, increases the risk then of bacterial infection because everything's sort of static, not flowing well, and then things like severe dehydration and autoimmune disease, which can create scarring from the inflammation in the passageways in those salivary gland ducts, can predispose to stones as well. The kind of treatment for small stones is just ensuring adequate hydration, moist heat, using anti-inflammatories like NSAIDs, and then again sialogogues. That would all hopefully get the stone to move. Now remember that the parasympathetic nervous system increases saliva secretion. Sympathetics tend to dry it up, make a thicker saliva. So making sure we are really working with parasympathetic-sympathetic balance. When, for example, the stomach channel is needled in Chinese medicine and acupuncture therapy, that actually increases, we think, the parasympathetic output to the upper GI system. And so that would be, stomach points would be one potential kind of approach to that. Shockwave therapy uses ultrasound to break up the stones a little bit. These stones are formed actually from dried up saliva, and they get little calcifications in there, so calcium deposits. So the sound waves can actually break up the calcium. And then surgery can be used to remove the stone as well. So that's a salivary gland stone, sialolithiasis. And then the final thing would be salivary gland tumors. And these can occur in any of the 3 major salivary glands or any of the thousands of minor salivary glands scattered throughout the mouth, the oral cavity. They usually present with a lump on the affected side. Usually this is a parotid gland tumor below the ear there. More common with older patients. And usually that's accompanied by duct blockage, and that can cause a very dry mouth, and that's called xerostomia because of lack of saliva. The majority, 85%, are benign, and they can be surgically removed. The malignant tumors are more difficult. They try to debulk the tumor, maybe, depending on the size and location. But then the tumor usually has spread, and so combination of chemo and radiotherapy are used. As you can imagine, these can be enormously disfiguring, and especially if radiation and lots of surgical debriding is done, that can lead to a lot of issues there. So that is a salivary gland tumor, just something to know about. Okay, from the mouth, we're going to jump down to the esophagus. I'm going to come back and talk about tonsil disorders in the respiratory system. So we're going to kind of skip that for the moment. We'll consider that in the respiratory section. But we'll jump down to the esophagus. The most sort of typical sort of disorders of the esophagus less commonly would be something called achalasia and esophageal varices. Remember, the varices are where especially in the distal esophagus, that the venous drainage is via the portal vein. So any backup of pressure in the portal system will cause bleeding in the lower esophagus, and people will cough up blood. I didn't put it on here, but there's another one called the Mallory-Weiss tear, and that happens usually from retching, extreme vomiting. It can happen in drug detox and things like that. And typically with bleeding from the varices or the Mallory-Weiss tear, if it's very acute, it can be bright red blood, but typically a lot of that blood has sat as the bleed is slower, it trickles into the stomach, it becomes oxidized there, and then a person vomits it out. And so it actually looks like coffee grounds. It's darker, they look like little coffee grounds. And so I've actually heard stories of nurses saying, hey, my patient's throwing up what looks like coffee grounds, but they haven't had any coffee today. It was from a Mallory-Weiss tear, and they were having esophageal bleed. And those will often need a surgical correction. More commonly with the esophagus, we have things like hiatal hernia, gastroesophageal reflux disease. I'm going to spend a little time talking about that, GERD. And then esophagitis, which is general inflammation, Barrett's esophagus, which is from chronic inflammation in the lower esophagus that creates scarring, and that's typically from acid constantly regurgitating up, so it can create a stricture in the lower esophagus. And then, unfortunately, Barrett's esophagus, a small percentage of those patients can go on to develop esophageal cancer. And we'll see there's actually two forms of esophageal cancer, squamous cell carcinoma, which happens more up in the upper esophagus, and adenocarcinoma, which is more common in the lower esophagus, and Barrett's is the main predisposer for that. And then the globus sensation is that difficulty swallowing sensation, plum pit sensation, usually in the upper esophagus. The typical finding with any sort of esophageal disorder is going to be dysphagia, and that is the medical term for difficulty swallowing. Often there'll be pain and bleeding. Now, interestingly, we often ask the question clinically with dysphagia, is it dysphagia to liquids, dysphagia to solids, or both? And so that would be important to differentiate. Usually, smaller tumors or obstructions or any esophageal problems will result in dysphagia to food, but there'll still be the ability to swallow liquids. But when it becomes dysphagia to both, then that's going to be more ominous in terms of what the underlying pathology might be. Red flags that require referral for further assessment treatment would be, again, dysphagia, whereas with solids, usually it can be just globus sensation, that would be benign, but it could also indicate a stricture or cancer, so that should be further followed up. Now, possible red flags for cancer, I'll just point out here, and we'll see this repeated over and over again, would be unexplained weight loss, where a person's like, yeah, I just lost 30 pounds over 6 weeks, and I haven't really been dieting. I've also been having night sweats, and especially if you feel any large cervical lymph nodes and whatnot. Those are all like red flags for cancer assessment. Again, this is going to be more typical in patients with very high risk factors like smoking, excessive alcohol use, but also older patients. And again, people with chronic acid reflux, this is always something we have on the radar, is esophageal cancer. Any swallowing associated with chest pain, so behind the sternum, and that again suggests inflammation of the esophagus, esophagitis. All right, so those would be some of the specific red flags for the esophagus. So let me start just talking about achalasia, which is a esophageal motility disorder. It's not common, but I have seen a few patients come through over the years with achalasia. It involves both the esophagus and the lower esophageal sphincter, which is that smooth muscle sphincter between the esophagus and the stomach. So what happens in achalasia is basically incomplete lower esophageal sphincter relaxation, increased tone, so it remains constricted. And then usually there is lack of esophageal peristalsis. So remember the esophagus has the smooth muscle, the two layers of smooth muscle in the muscularis layer of the esophageal wall. And there are those motility waves, peristaltic waves, that push the food down. So there's decreased peristalsis, increased constriction, and as you can imagine, that's going to result in a painful obstruction here in the lower esophagus. It becomes dilated. So if you look, for example, at this barium swallow x-ray, you see what they call a bird's beak appearance. So it's basically, this is the barium up here in the esophagus. Throw out in the red here. It's all getting trapped. And this is the lower esophageal sphincter right here. Notice it's very constricted. That's a classic finding in achalasia. So there's going to be difficulty swallowing, regurgitation, sometimes chest pain, angina-like. The diagnosis is going to be using the barium swallow x-rays, but also something called esophageal manometry, which is able to measure the pressure in the esophagus to see if that's increasing. The patients that tend to present with this, I've seen a couple of actually teenagers. So we think it has to do in some patients with the autonomic nervous system and the enteric nervous system not properly developing in the esophageal wall. And so we get this dysmotility. I've actually supported them by using acupuncture, but also herbal therapies to increase the parasympathetic tone. And I know in one girl that really helped. She was really anxious, and the anxiety would really trigger her achalasia. Usually the treatments are, for more minor cases, diet changes, eating smaller portions, eating more slowly. There are medications that are given. Nifedipine is what's called the calcium channel blocker. Calcium is needed for smooth muscle to contract. So this is the calcium inside the smooth muscle cells that's stored in a special little organelle called the sarcoplasmic reticulum. And when the muscle fibers need to contract, the sarcoplasmic reticulum releases calcium, and that causes contraction. Well, calcium channel blockers inhibit that process. We'll see this class of drugs used very commonly in cardiovascular disorders because they also vasodilate. They also allow the heart muscle to contract less forcefully. And so that can be helpful for a lot of different cardiovascular conditions. Nitrates are another cardiovascular drug. These are vasodilators, but they also relax smooth muscle. And so that would help to try to relax the lower esophageal sphincter. And then paradoxically, Botox also, and that's really going to work by inhibiting the skeletal muscle tone. And just like it does in the face and other areas where it's used cosmetically, but here it's being used therapeutically. Dilation of the lower esophagus can be done. That's called pneumatic dilation. But several patients I've seen have had to eventually undergo surgery, and this is there's different techniques. One is called fundoplication, and that's where basically the sphincter is kind of overrided. The stomach is brought up and wrapped around to create another functional sphincter here that can more efficiently open and close. So that's the surgical approach to achalasia. But again, treating supportively, you might think about the autonomic balance and working with that. Esophageal varices, I mentioned, usually this is where those veins dilate. We see this in conditions like portal hypertension from liver cirrhosis, and that can result in life-threatening hemorrhage. The real treatment here is, of course, monitoring, but trying to treat the underlying condition, cirrhosis. There are different surgical techniques that can be used to try to stop the bleeding once it happens, but often, as you can imagine, the bleeding can be severe in some cases and can be life-threatening. Person bleeds out, they lose a lot of circulatory volume, and they go into what's called hypovolemic shock. We'll talk about shock later, but shock can progress to the point where it's fatal. So the best treatment there is prevention. And then hiatal hernia, let me say something there. So this is where a portion of the stomach usually goes up through the diaphragm. So remember, the esophagus is going through the diaphragm. In a simple sliding hernia, usually the cardia region kind of just flips up and goes up there. In a paraesophageal hernia, the whole fundus can go up, and even more, even sort of the body can start going up into the chest cavity. So those are the two different types of hiatal hernias, the sliding hernia and paraesophageal. This can cause, you can imagine, a lot of heartburn because the lower esophageal sphincter doesn't function, and we get acid regurgitating back up onto the esophagus, and they can also create dysphagia. Sliding hernias are usually just treated with kind of symptomatic or conservative measures, things like non-surgical treatments like heel drops, where a person swallows a glass of water and then they actually stand and they drop on their heels several times, and that pushes it down. Chiropractors and some naturopaths have a manipulation technique. They pull the stomach back down, pull it down. So those are some potential treatments. I again tend to find this is a motility issue involving poor vagus nerve function. So remember, the vagus is your main parasympathetic nerve. So if it's not functioning, you're going to get bolus of food sitting up here, pressure builds up, usually from fermentation, and then it's going to push back up the stomach. And so if you keep pushing it down, it's not going to do much. You have to really improve the motility. So just supporting the stomach chi and the yang activity is, I think, probably the best thing in those cases to really address that. Now, paraesophageal hernia is more concerning. That actually is, fortunately, less common. That can happen from traumatic injury, like injury to the abdominal cavity, like a car accident, they hit the steering wheel or something. And these should really be treated surgically, where it needs a surgical repair to keep that stomach from prolapsing back up. So fortunately, those are less common, but definitely they're going to be more severe. All right, so very, very common illness that we see almost daily in the clinic is especially if you work with a lot of patients with GI issues, will be chronic acid reflux. And when it's chronic, we call this gastroesophageal reflux disease. So heartburn is technically just kind of occasionally, you get after a meal, you get a little heartburn. But when it's chronic, happening every day for weeks and months, then we have a different story going on here. So the clinical presentation is usually heartburn, it's burning, we might get retrosternal pain, a rising sensation after meals. Very common to trigger maybe a cough reflex, irritation in the throat. So a lot of people think they have a respiratory issue or allergies, and it's actually chronic GERD. There might be an acid taste in the mouth, heartburn, bad breath, tooth erosion from the chronic acid coming up, and then chest pain, difficulty breathing. Chronic sore throat, that's another important differential for chronic pharyngitis, sore throat, and then a globus sensation, potentially vomiting. That's not as common. Complications are going to be from that acid hitting the esophagus. Remember, esophagus has really no mucosal defenses for acid, unlike the stomach lining. So we can get inflammation, esophagitis. Over time, this can create the Barrett's esophagus, which really creates the esophageal stricture. And that is precancerous. And so Barrett's is really esophageal metaplasia. What happens is that the squamous epithelium of the esophagus is replaced by columnar epithelium, which is more typical of the stomach. So it's almost like the stomach cells are it's moving up into the esophagus. It's really the esophageal cells undergoing metaplasia. But they can then become dysplastic, and dysplasia is very early cancer, and that can lead to esophageal adenocarcinoma. We'll again look at the different esophageal cancers here in a bit. Risk factors would be having a lot of abdominal weight or pregnancy. That can create more of a tendency towards hiatal hernia. Smoking is interesting. Cigarette smoking relaxes the lower esophageal sphincter, and so it's going to be more common. In fact, we think the real problem here is decreased lower esophageal sphincter tone. So that is what's going to allow the acid to come up. More common in males, especially older males, high fat, sugar and salt diets. High fat diets keep the food in the stomach longer, remember, and so there's going to be more of a tendency for, as that food is going back and forth in the stomach, for it to regurgitate back up into the esophagus, especially if there's weak lower esophageal sphincter tone. Different medications like antihistamines, but also those calcium channel blockers like the nifedipine I just talked about, they are smooth muscle relaxants. So although they're important for achalasia, where you have an LES constriction, not so good here. And even some antidepressants and different sleep medications can actually relax the lower esophageal sphincter too much. So the causes would include, again, the lower esophageal sphincter tone. We have decreased stomach peristalsis with decreased acid secretion in a number of patients, not all of them. I would just estimate about 80% of the patients I see with chronic GERD actually have normal to low stomach acid, versus about 20% actually have elevated stomach acid. And the lower stomach acid is an issue because basically food will, again, just sort of sit in the stomach longer, it won't go through, and that can put pressure on the lower esophageal sphincter. And this often goes along with decreased vagus tone and often increased sympathetic tone. So there again, techniques to do vagal balancing, including acupuncture, can be important here. Now, interestingly, we know that there are actually receptors for melatonin as well as a lot of other neurotransmitters in the lower esophageal sphincter. And we know that low melatonin, hypothyroid states, as well as increased stress hormones, all can relax the lower esophageal sphincter. So I'm looking at that often when I'm looking at treatment for chronic GERD in patients. Now, there's a type of esophagitis which is not due to acid reflux, it's due to increased eosinophils. This is an immune cell we often see associated with allergic conditions. So eosinophilic esophagitis is another differential, and that usually can only be differentiated by scoping the patient with an endoscope. Now, unlike other conditions of the stomach we'll see, H. pylori, remember that bacteria that lives in the stomach, actually appears to be protective here, not a problem in GERD. So paradoxically, here we actually find H. pylori is beneficial. So here is some pictures, just some drawings here with normal LES. You can see the Z line. It has a kind of a fairly normal appearance. Remember, the Z line is the stomach mucosa in the red, and then the more pale is the esophageal squamous cells. In Barrett's, you lose all that. I mean, look at this. The sphincter remains open, lots of scarring here, and that can actually become strictured over time, so become narrow. So now you swallow something, it gets stuck there. And so that would be from that chronic reflux. Notice too, in Barrett's, it's like the stomach mucosa moves upward here. So it's almost like the descending nerve sensory forces are not as active here. These more metabolic forces are moving upward. So that is the kind of overall kind of pathophysiology here of GERD. Okay, let's look at the assessment and treatment here of GERD. So with assessment, we're going to be looking at any symptoms, of course, of heartburn regurgitation in the history, looking at the severity, timing, sort of what triggers it, any presence of anemia just by inspection. So is there pallor, is there pale nail beds, things like that. But then we're going to use some labs to confirm some of this. So using a CBC, complete blood count, to confirm anemia. Again, anemias are many different types, but the most common one would be here from an iron deficiency. You can also have a B12 deficiency or folate deficiency anemia. Then there are many other types of anemias from chronic blood loss, things like that. We'll get into that when we discuss hematology. But here we're focused more on iron, B12, and folate. Ferritin is your iron store in the body, so that would be another important thing to look at. Your complete metabolic panel to look at the electrolytes and whatnot. That's not going to be as important here. That's going to look for more malnutrition if you suspect that. But the most important test probably for if we suspect any bleeding is going to be things like the fecal occult blood test, the FOPT, or the fecal immune test, the FIT. Very importantly, bleeding in the GI tract will be usually invisible. In other words, you look at the stool, it might look dark, but for most people, they don't notice anything, especially if it's a slow chronic bleed. And bleeds can be more common with cancers, with actual ulcerations and things like that. So this is an easy test to just tell us, do we need to be worried about that? What we do is you take a stool sample and you put on this little card, and if there's any hemoglobin in the stool, the card will turn color. A FOP test, you had to avoid a bunch of foods before doing it. Now we prefer the FIT test usually, but not all insurance covers it. But the FIT test will tell us if there's any hemoglobin in the stool. If you see blood on the stool, that indicates if it's on the surface of the stool, looks like it's been wiped on there, that's usually bleeding from a hemorrhoid or an anal fissure, rarely an ulcerative colitis you get, or Crohn's, you can get proctitis, and rarely a cancer. So that would be on the surface of the stool. If you see blood, actual red blood mixed into the stool, that's bleeding usually as high up as the sigmoid colon, but not higher. But most bleeding higher up in the GI tract, you will not see as red in the stool. If anything, it looks dark, and that's called melena. Melena is a dark stool. So melena is dark stool, and again, if it's a slow bleed, you might not even notice that. So that's why we use these tests. Now, one of the things we always look for is the presence of any red flag symptoms, and these would require further workup. So for older patients over 50, patients with symptoms over 5 years, unexplained weight loss, night sweats, unexplained blood loss, like or seeing the melena, or the hematemesis, which is throwing and vomiting blood, anemia, iron or B12, recurrent vomiting, dysphagia, difficulty swallowing, and then epigastric mass palpated on abdominal exam. These would all be red flags. They're going to need usually a fairly urgent endoscopy to investigate this further. But for patients who don't have the red flag symptoms, or we're not too worried about any other GI disorder, the biomedical approach is to do an acid blocking medication for 1 to 2 months and taken before meals, 30 to 60 minutes. If that solves the problem, if all the symptoms go away, that kind of confirms the diagnosis. Now again, the problem is not of the acid, it's of the lower esophageal sphincter, but if you suppress the acid enough, which of course we'll talk about here in a moment, has its own side effects, own problems, But if you suppress it enough, then it will stop the inflammation in the esophagus, and that kind of confirms the diagnosis. Endoscopy is going to be reserved for people with the red flag symptoms. So we're going to look for any complications, potentially exclude others. So when we're not sure, we might just order the endoscopy. Definitely checking for Barrett's, what's called erosive GERD, which is when we have erosion of the mucosa from the acid. Looking for strictures. We can also treat the strictures, so the endoscopy can be used to inflate a balloon at the base of the esophagus, and that opens up the lower esophageal sphincter, so that can treat strictures. We rarely use now barium swallow or the esophageal mammometry, which checks for pressures. We used to do pH studies of the stomach. Some naturopaths still do. It's called the Heidelberg test. That's one method. You can also swallow a string that has pH indicator on it, and then you pull it up, and then you can see if it's changed, see how much stomach acid you have. So that would be investigating people with low stomach acid, where the food is just sitting in the stomach, and that's what's pushing up on the lower esophageal sphincter. H. pylori studies, again, H. pylori we think is more protective here, so it's not going to be as useful. Now, for treatment of GERD, it's really going to depend on, number one, removing obvious offending agents like cigarette smoking, things like that, but then following the therapeutic order. So again, red flags and so forth, we're going to look at jumping to level 4 for endoscopy, and then medications I'll talk about here in a minute. But then, if we don't have those red flags and we think this is like a case of GERD that's been happening for maybe less than a year, maybe younger patients, and so forth, we can target the step 1, the level 1, level 2 therapies here. So diet, increasing fiber, vegetables, lean proteins, decreasing fat, simple sugars, salt, decreasing spicy and acid foods. Nightshades, I put a question mark. Some people do react to tomato, potato, nightshade, again, tobacco poorly. With their GERD, decreasing coffee, alcohol, chocolate. Chocolate's a smooth muscle relaxant on the lower esophageal sphincter. And then weight loss would all be indicated. Exercise, smoking cessation, and then psychological support, CBT, relaxation therapy. In terms of patterns in Chinese medicine, level 2, most common would be the spleen stomach qi deficiency. That would be the low vagal tone, low acid, low motility picture. The stomach heat would be more the high acid. That would be the people that actually have hyperacidity and so forth, and more inflammation. Patients usually do worse with any sort of acid-stimulating therapy like enzymes or vinegar, worse with heat, worse with pressure, maybe redness on the tongue. Liver invading spleen would be the bile reflux, which we don't really have a way to test, although if a person throws up, during the reflux, they might have greenish-looking vomit, and that would indicate more the bile being present. But we usually assess that through our pulse diagnosis and other things. And then stomach yin deficiency would be more of a dryness pattern, which is going to be more applicable to the stomach specifically. But again, we can include esophagus and mouth in the stomach, Chinese medicine organ of the stomach. The biomedical approach, again, would be not just using PPIs as diagnosis, but also as long-term treatment. So they're usually started one time a day with breakfast and kind of upped from there. Now, unfortunate thing about PPIs, and I'll go into them here in just a moment, is they can really lead to acid hypersecretion if they are abruptly stopped. So that's a really tricky thing to get people off PPIs if they've been on them for a long time. 75 to 90% will relapse after 6 months after PPI withdrawal, which means that PPIs are really not solving the problem. They're purely a Band-Aid to protect the esophagus, which is better than nothing, but they have their own adverse effects. About 20 to 30% don't respond to PPIs and have persistent symptoms, and that's again because they probably have bile reflux or other things going on. Compliance is usually very poor long-term, as you can imagine. And lots of risks. I'll just go through them here and we'll talk about them in more detail in a bit. But, headache would be one, diarrhea. But real problem with increased infections, C. difficile, creating chronic diarrhea. Pneumonia and chronic sinusitis are the 3 big infections that we know are correlated with chronic PPI use. Having low B12 levels from decreased B12 absorption, and then decreased calcium, magnesium, and probably other trace minerals too. leading to osteopenia, osteoporosis, and in the case of B12, macrocytic anemia. So definitely not without risk. They're very commonly used, but this is one medication I really try to get my patients off of because we have many other things that can be helpful. H2 blockers are an older class of acid blocker. They block those histamine receptors on parietal cells we talked about, and they decrease the secretion of stomach acid. So usually this is often patients are transitioned from a PPI to an H2 blocker. At least that's what they should happen, but that's not what happens. Typically, they usually stay on PPIs forever. There is surgical management for patients who really don't respond to the medical management. Maybe they don't have options to do the other supportive therapies. And the one is the laparoscopic Nissen fundoplication. And that's where, again, a portion of the stomach is actually wrapped around to sort of create a false lower esophageal sphincter. And that can help prevent further reflux. So those are some of the treatment options we have available for GERD from the perspective of the therapeutic order. Right, so let me say a little bit more about acid blocking agents, stomach acid blocking agents. There's really three main classes. So we've talked about two, the PPIs and H2 receptor antagonists, but there are what we just call antacids. And these are over-the-counter things like calcium carbonate, that's Tums, Pepto-Bismol, Rolaids, sodium bicarbonate, that's Alka-Seltzer, magnesium hydroxide, that's milk of magnesia and Rolaids, and aluminum hydroxide, that's Gaviscon, Maalox, Mylanta. All of these are basic, they neutralize stomach acid, and they are really not indicated for long-term use. They have a very short duration of action. So if people take these and they continue to have chronic reflux, that really is a GERD picture, and antacids really are not the appropriate therapy for that. So be sure to kind of remind your patients of that. Adverse effects with the excess calcium is something called milk alkali syndrome. That can actually lead to renal failure and alkalosis in the blood and hypercalcemia in the body. Too much calcium in the blood. The carbonate can create, again, alkalosis, predisposed to kidney stones and muscle weakness. The aluminum in the aluminum hydroxide, this can create insoluble aluminum phosphate complexes, hyperphosphatemia, excess phosphate in the blood, and cause weakening of the bone, osteomalacia. And then magnesium hydroxide, powerful laxative, and this is mostly benign in most people, but can create elevated magnesium in renal failure patients. And the sodium in the sodium bicarbonate, the Alka-Seltzer, can increase blood pressure and increase the risk of heart failure for those who are predisposed. So, wow, lots of adverse effects on these, and again, that's why we don't recommend them for long-term therapy at all. The H2 receptor antagonists, examples here would be cimetidine, Tagamet, ranitidine, Zantac, famotidine, Pepcid, and the Axid. I don't see that one being used much anymore. But these first three in particular, very commonly used. These, again, decrease HCl secretion by blocking the H2 receptors. Longer duration of action. Again, they should be used maybe more chronically for patients, transition them off the PPIs if they have nothing else available. And they're often used prophylactically before meals to reduce heartburn. Sometimes we see the ranitidine used actually for interstitial cystitis. That's a chronic inflammation of the bladder that's not, we think, not due to infection. And this helps as an antihistamine to actually block the mast cells. Now, antihistamines, these are antihistamines, but they are H2 antihistamines. Most of your allergy antihistamines are H1. So the H1 receptor is on the immune cells, and that's things like, Zyrtec and Allegra and Claritin, all those are H1, Benadryl, H1 antagonists. These are H2 antagonists. So except for ranitidine, there is little application here for allergies. Adverse effects, pretty well tolerated for most. Hypotension is one problem. Headache, fatigue, dizziness, diarrhea, constipation, rash. That's pretty common for a lot of medications. Men can experience gynecomastia, loss of libido, impotence, potentially by suppressing androgens, increasing estrogen. And then there are lots of interactions with other drugs through the P450 detox system in the liver. We'll talk about that later. And then potential cognitive decline, especially in African American patients, has been documented. So not without adverse effects there. Proton pump inhibitors, we talked about, these block the secretion of hydrogen ion from those proton pumps in parietal cells. They are now the most potent antacids, but they're now available, many of them, over the counter. So things like Prevacid 24-hour, Nexium 24-hour, Prilosec over the counter. And they can also be prescribed at higher dosages. Generally well tolerated. Short-term effects, though, are headache, nausea, diarrhea, abdominal pain, fatigue, dizziness, low magnesium, low B12. The big problem, though, is the long-term. Decreased mineral absorption, calcium, magnesium, B12, probably others. Increased fracture risk, especially of the hip because of the low calcium. Increased infections of the lung with community-acquired pneumonias, C. difficile, and I mentioned sinusitis. And then dependency. People become dependent on these. And that real increase of acid secretion after discontinuation, even tachycardia. Now, a common thing that can happen, well, not common, fortunately it's rare, but it can commonly happen with different medications. So many medications this happens with. There's very rare adverse effects that include what's called erythema multiforme, it's a skin rash, pancreatitis, Stevens-Johnson syndrome, and that's basically where the immune system attacks the proteins that keep your epithelium in place on the surface of the skin, so the skin sloughs off, and that can be minor, like happening in the mucosa of your mouth or whatnot, but it can also cover a huge portion of the body. And I've seen a couple patients that are recovering from Stevens-Johnson's, and it looks pretty horrific. But that is we can't really predict who's going to develop that, but that is an immune reaction that can happen with many, many different medications, but that includes the PPIs. And then acute nephritis, which is kidney inflammation. So again, this is why I like to get patients off of these if at all possible. That said, if they've been on it for years, it's not easy. But we certainly can try with our acupuncture, herbal therapies, all of our other things we have available. Finally, let me just say a few things about esophageal cancer. First of all, benign tumors are uncommon in the esophagus. So unfortunately, there are leiomyomas, which are smooth muscle tumors. They're very rare. But most of the tumors in the esophagus are cancerous. And they vary. There's two main types. So squamous cell, remember the majority of the cells lining the esophagus are squamous cells. And then adenocarcinoma. The squamous cell is going to be more common in males. This is actually the one that's most common worldwide in terms of a type of esophageal cancer. And it presents mostly in the upper and the middle esophagus. And it's highly linked to smoking, chronic alcohol use, nitrates from like preserved foods, smoking, opiates, fungal toxins, radiation, and lye exposure. So these are the kind of known causative effects of squamous cell carcinoma. So that's going to be the one that's going to be more common worldwide. Adenocarcinomas are the most common cause of esophageal cancer in the U.S. And these are going to happen more in the lower esophagus, usually associated with GERD and then Barrett's, chronic Barrett's. This is where the cancer will actually spread through regional lymph nodes and the metastases occur early. So this is why we are really concerned about people presenting with any of the red flags and with the chronic reflux, is to be sure we don't miss catching these early, because the treatment is much more effective in the early stages. Very poor 5-year survival, because a lot of people don't get these diagnosed until they have already metastasized throughout the body. Fortunately, it's a fairly uncommon type of cancer, but it does cause about 2% of all cancer deaths in the U.S. And it's going to spread locally through lymph nodes to the lungs, liver, and then the pleura around the lungs. Probably the first presentation is going to be dysphagia. And whenever you have dysphagia, that's going to pretty much indicate that over 60% of the esophageal circumference is already involved. And usually by then, the disease is actually incurable. So again, early detection is really the key here. Weight loss would be a later symptom, chronic cough and hoarseness, and this can happen especially in the upper esophagus with compression of what's called the recurrent laryngeal nerve. That's by your thyroid. And that innervates your voice box. It's actually a branch of the vagus nerve. And tumor compression can create hoarseness because of that. So that is esophageal cancer, so squamous and adenocarcinoma. The treatment here would be first assessment through imaging and endoscopy, and contrast using contrast agent with x-rays, maybe CT scan would all be the typical imaging there. This one's difficult to treat because, again, by the time it's diagnosed, it's often spread. So surgery is difficult because you can't really remove the esophagus. Now, there are a lot of research going on into artificial esophaguses, growing esophaguses as different organs. It's an interesting area of exploration right now, and so forth. But you can't obviously cut out your esophagus because you need that to eat. And so usually for more advanced lesions, the treatment is mostly palliative. Very poor prognosis. Many patients are inoperable by the time they're diagnosed, and the survival rate 5-year is only 25%. Most patients will die of bronchopneumonia. That's the proximal cause of death. So again, here, early detection is the best. So again, final plug for why we are concerned about chronic GERD and why we want to make sure we properly assess that. So that is a summary of your upper GI disorders. The first part here, I'm going to jump into the stomach in the next video.